Muran, do you want us all on while we, or do you want us off until you introduce us? Do you want us all on in the beginning?
Yeah, I think that's a good idea.
Okay.
I'm starting seeing some attendees joining, so I would like to welcome them. We're going to start in around 10 minutes or 8 minutes exactly. So welcome everyone.
Yeah. Mm.
So for the attendees who started to join us, just saying it again that we are starting in around 7 minutes. Thank you for joining us. While waiting for everyone in order to break the silence, would anyone share what's the weather situation in the US maybe?
You mean pandemic-wise?
Yeah.
Or any-wise?
You can talk.
Yes, so you know, Florida right now is the numbers are coming down, but it is definitely an epicenter around the world for COVID. We did not do as good of a job, I think, as all of you did as shutting things down. But hopefully the numbers, they're starting to drop. Unfortunately, our kids are starting to go to college, and I think that's going to see a bump up because of that, back to school.
We had a bit of raise in number of cases over the last 3 days. So in UAE, we started seeing around 1,000 daily cases over the last 3 days. And the school started around a couple of weeks ago. I have elected for my kids to go to study online. There was the choice for everyone here in UAE, whether you have part-time schooling or like studying online. So I elected for my kids to study online. And lucky enough, a couple of days ago, they announced that there was a good number of cases coming from school.
Yeah, you did the right thing, I think. My daughter is a freshman, started her freshman year at UMiami, and she, they have a curfew at 10 o'clock at night. So although she loves it, she feels like she's not getting the full experience because, you know, this is not what college is about as a freshman. You're supposed to be able to go out and go to parties and meet people. And so she, you know, but I said, it's all going to be normal, hopefully soon.
We are hoping like in like 4 month time, we're not sure what's the situation gonna be, but hopefully after December, things gonna start to get better, or maybe not. We will have to see.
Fingers crossed.
Just trying to snip some hot tea just to keep the virus out.
I'm not sure how much this is gonna help.
All loaded up with vitamin C.
And
That's
zinc.
exciting. How's the practice, Anat, with the COVID? Did you stop and then you restarted?
We did. We shut down for about 2 months. We only saw emergency cases and we didn't do any elective surgery. And then we restarted, but we are not at the volume that we were before. And everyone who has surgery needs to be tested before surgery for COVID.
That's, we are all almost doing the same here. We are restarted by early July, almost trying to be at full capacity, but the patients are still reluctant to come. So I wouldn't say we are in a full capacity, but I agree, every patient going to the OR, I work in a general hospital, so any patient going to the OR needs a COVID test 48 hours before the surgery, whether it is topical or GA. And luckily, so far we are doing very well, but we are preparing for possible second wave.
I think we are in the middle of that right now, actually.
That's after the last 3 days.
3 days were an eye-opener.
How is the situation in the UK, Saj? I know that from the fellows over there. I still have contact with them, but let's hear from you.
It's fine. Things are going back to normal. So I think they're testing more people. So there's a lot more people becoming, showing up as positive because of asymptomatic positives. But actually, the death rate's still low. We'll know in a few weeks what's happening because the school children went back last week. So
that's true.
The real spreaders.
Right.
Well, it's hard to keep university kids isolated. It's not in their DNA. So my daughter, who is a little bit of a goody two shoes, is staying in and abiding by the rules and wearing her mask. And there are kids going out and renting hotel rooms and partying and bringing it back to the school. So the poor thing is like, wait a second, I'm not going to be able to get the fun of going out and I'm still going to be at risk? How does that work? So yeah, it's hard. They are the spreaders for sure.
Yeah, most of the spread here in Canada has been with young people. So the numbers have gone up a little bit. They've gone up to 200 in our province per day, which is an increase. It's almost doubled in the last week. But it's mostly them, people wanting to party. And they're all very young. And so they're going to start cracking down, and they may go back and crack down a bit more. The only thing that seems to work is to limit things.
Yeah.
Okay.
The problem is how long you can do it for. That's the
We are only waiting for the vaccine. We are hoping for it.
Well, I think this week's results weren't very good, were they? So the transverse myelitis case from the Oxford vaccine trial.
Mm.
So
I think I'll wait.
That's kind of expected, and that happens all the time. I think people are being inappropriately optimistic. I mean, this is what happens. So, yeah.
All right, I think it's 8:30 now, so we will be starting. I see a lot of attendees already joined, so I would like to welcome everyone. I would like to welcome everyone for this webinar. It is organized by the Emirates Society of Ophthalmology and sponsored by Allergan. I would like to take this opportunity to thank our sponsor, Allergan, for supporting the Emirates Society of Ophthalmology webinars and several conferences. So thanks for Allergan and Ahmed Asal and his team for organizing this with us. This is accredited with this webinar is accredited with 2 CME hours. For the participant and attendees, you will receive an email with the CME certificate. It's going to be the same email you are using for registering for this webinar. My name is Muran Obthani. I'm a cornea consultant in Abu Dhabi. I have Hamad Anwar. He is co-moderating this session with me. He works as a cornea consultant in Moorfield Eye Hospital, Abu Dhabi. We have an excellent group of speakers. I'll start to introduce them one by one once we get into the lectures. And we have a very rich agenda. We will keep the timing, so we will probably postpone the questions until the end of the webinar. You can type your questions at the QA section. And I think without further delay, I would like to introduce our first speaker. Our first speaker is Dr. Anat Galor. She is a cornea and uveitis trained specialist working at Baskin Palmer Eye Institute, University of Miami. Dr. Galor currently runs the Ocular Surfer program at Miami. Her focus in her research is understanding the mechanism of pain and dry eye symptoms. She will present today about the pain and sensation of ocular surface disease. Dr. Galor, the podium is yours.
Okay, thank you so much for having me here. Can everyone see my screen?
Yes, and I'll ask the other speakers to turn off their cameras and mics. Thank you.
Okay, so I'd like to take you on a journey to a disease that started a long time ago, a disease called Sjogren's, right? And when we saw patients that had corneal staining and low tear volume, we said, hey, this eyeball is telling me that they're dry. And oftentimes these patients would also have a wattle bottle in the hand. So we got all excited about dry eye. And then there were these population-based studies. And it turns out a lot of people said that their eyes felt dry, right? But it didn't make sense because when we started looking at their eyes, many of the people who said their eyes felt dry didn't have dry eye. They didn't have the eye that I showed you of a patient with Sjogren's, right? It's so confusing. So we said, no big deal. Let's just include more stuff. Let's talk about abnormal tear health, right? We'll start talking about fast evaporation, lid margin disease. We're going to develop some point of care tests. We're going to look at tear osmolarity and inflammation, and then it'll make sense. But it turns out it didn't make sense because these newer metrics didn't correlate with the eyes feeling dry either, right? So we're still back to baseline. So let's take a step back and talk about dry eye. What is it? Well, right now it's an umbrella term and we throw a bunch of apples and oranges, and by that I mean different symptoms and different signs. And if that's not confusing enough, when you think about symptoms, we still have apples and oranges, and by that I mean pain symptoms and vision-related symptoms. So let's take a step back because I may have made you a little uncomfortable. I used the word pain when I talked about dry eye. So what I'm talking about when I say pain is an unpleasant sensory and emotional experience. And you can see that people will use different words to describe how their eyes feel. Some people use the word burning, some sharp, but most people use the word dry. And it doesn't mean that the dryness experienced in people who are said to have dry eyes the same as the pain that people have when they have scleritis. It just means when we use the word pain, we think about nerves. And it turns out we have lots of nerves in our cornea, and their job is to sense the environment and send information up to the brain. And they sense different things. They sense evaporation and heat and touch. And it turns out it's not just one nerve, it's a combination of nerves, and pathways for sensations of dryness may be different than that of sharp, but it's still about nerves. And this makes ophthalmologists feel very uncomfortable because we have been taught that we look at the eye and we see all the answers. But when it comes to sensations of pain, there's a whole network that we can't see. And we like to see what we what's in front of us. So there's a primary nociceptor, and then there are secondary and tertiary nerves that connect the ocular surface to the brain. So we're gonna revisit the terminology. We're gonna start with ocular surface pain, which can be any sensation, dryness, burning, aching, tenderness. And we're gonna think about those unhappy nerves, and now we're gonna be detectives and figure out why are the nerves unhappy. And it turns out that if your eye is dry, the nerves are unhappy. So let's put that under our umbrella, but many patients who say their eyes feel dry don't have dry eye. So what else? This is one of my patients who has sensations of dryness. And hopefully you can see here that there are some folds in the anterior conjunctiva and an expanded central tear lake. And this patient has conjunctival chalasis as a cause of his sensations of dryness. What about this person? Her eyes feel so dry. And when you start tugging at them, you see that they're totally lax. There's papillary conjunctivitis on the upper lids, and this is floppy eyelid syndrome manifesting as dryness. So the idea is any conjunctival or eyelid issue can give you dry eye symptoms. And so normally I like to test my audience. I can't do that over Zoom, but hopefully you guys are looking and you can see that here is our source of dryness, a spastic entropion. This one is a little more subtle, but this is a newly diagnosed thyroid eye disease, and hopefully not as subtle. The location of staining can help. This is a case of exposure-associated dry eye symptoms. So just like conjunctiva and the eyelid, any corneal issue can also cause dry eye symptoms. Here's an example of MAP dot dystrophy. Here's an example of Salzmann. All patients who came in saying that their eyes felt dry. And so let's put anatomical disturbances under our dry eye umbrella. What about this person? It's only her left eye that feels dry. Let's look here, use our detective hat. It turns out she's only using glaucoma medications in her left eye. So let's add toxicity to things that make nerves unhappy. And so everything I've been talking to you so far, these are sources of nociceptive pain. That means there's something in the environment that's causing the nerves to fire. But the thing that we often don't think about is that the nerves themselves can become dysfunctional. So if you perform any ocular surgery, like LASIK or cataract surgery, the nerves that are damaged can become more sensitive. And there are people who have traumatic brain injury, migraine, and fibromyalgia who have abnormalities in their central nerves. And when you have nerves themselves causing pain, we call that neuropathic pain. But here's the problem. If you have chronic dry eye or anatomical changes or toxicity, the peripheral nerves can become abnormal. And if the peripheral nerves are abnormal for a long time, then the central nerves can become abnormal. So you can end up with any one of these from any starting point. And if that's not confusing enough, sometimes the nerves are not transmitting signals appropriately. We call that neurotrophic keratitis. But there are some nerves that are still functional. And so you can actually have decreased sensation, but the nerves that are there are abnormal and transmit pain. And here's another challenge. You can come in and you can have diffuse corneal staining, and you can say, my eyes feel dry, burning, and aching, but your ocular surface can look totally normal, and you can come up with the exact same sensation. And so the punchline of my talk is that nerve status has to be considered when evaluating a patient with dry eye. So if nothing else is remembered, this is the punchline. And it's a problem because right now, in most cases, a patient comes in and says, my eyes feel dry, and the eye care provider says, well, then you must have a tear problem, and we need to get away from that. So how do I think about ocular surface pain? I think about ocular surface status on the x-axis and nerve status on the y-axis. Nerves can be normal, they can be hypersensitive or hyposensitive. And you can have a person that comes in and they have a problem on their ocular surface and their nerves are normal. You can have someone who has decreased sensation, but other than that, their ocular surface looks good. You can have people with increased sensation and a normal ocular surface. But the reality is that most patients have more than one thing, and we just have to accept it. So If nerve status is so important, how do we detect nerve alterations in humans? Well, I'll tell you what I do. The first thing I do is I look for specific risk factors, like have they had recent ocular surgery? Do they have comorbid pain conditions like migraine and fibromyalgia? I also look for specific symptoms because people with neuropathic pain often complain of hyperalgesia. That means something that hurts me a little bit hurts them a lot. So when someone comes in and tells me they're so sensitive to wind, I think, this could be neuropathic pain. Same thing for allodynia, which means something that shouldn't hurt at all hurts someone with neuropathic pain. And the sign that I'm looking for is someone that comes in and tells me room light kills me. I say, this is allodynia. This could be a symptom of neuropathic pain. Then I look for specific exam findings. I like dental floss, and I check corneal sensation on a qualitative basis. And what I'm looking for is an abnormality. I also have trained my technicians not to put proparacaine in any patient who I'm doing a pain evaluation, because if they have persistent pain after proparacaine, then I start thinking about central or non-ocular sources of pain. And overall, I'm looking for symptoms out of proportion to signs of disease. And I incorporate these tests into a quick but comprehensive exam because I also need to understand what's happening on the ocular surface. I do have a confocal machine, and I use it to look for density, tortuosity, and dendritic cells. And there have been a few groups that have talked about microneuromas as a marker for corneal neuropathic pain. But there's still some controversy. What's a microneuroma versus a turning point of the nerves? How can I differentiate normal from abnormal? And another problem is that my confocal has a very small field of view, and it doesn't image central nerves. So I use it, but I recognize the limitations. But as eye care providers, what we care about most is how do we treat pain? And so the first thing I do is I treat all nociceptive sources of pain. So everything that we've already been taught to do in quote dry eye actually makes nerves happier and healthier. So that's what I do first. But the unmet need is to recognize that in some cases you've done all you think you can do and the pain persists. And that's when you need to start thinking maybe there's nerve dysfunction that needs to be addressed. And this is a patient that I see every week, someone who had surgery, who has been diagnosed with dry eye by a variety of ophthalmologists, and finally one, a year later, recognized that it may be a nerve problem. And these patients come in and they're frustrated and they're frightened and they're anxious. So recognizing that nerves may be abnormal is really important early on. So how do I modulate nerves once I have identified that they may be a problem? So if the problem is in the peripheral nerves, I like to try blood products. And there's a thought that maybe growth factors like nerve growth factor and platelet-derived growth factor are helping heal the nerves. But I use my proparacaine challenge, and if I think that the pain is central, I don't have as much success with topical therapies. And that's when I think about how do I modulate central nerves. I like oral agents. My go-to are pregabalin and gabapentin. And because so many people have anxiety, I also like to combine it with duloxetine. And if that doesn't work, I go to a tricyclic antidepressant. And especially in patients who have comorbid pain conditions, I love this approach. I've also learned from the pain specialists that there are a lot of adjuvant therapies that can be used to treat ocular pain. And one I like is a TENS unit. This is a Cephaly, which is FDA approved for migraine. And when I wear it, it's pretty comfortable. And it also makes me feel a little bit like Wonder Woman. So someone who's already using TENS elsewhere for back or knee pain, they tend to like this idea and successfully incorporate it. So this is a treatment that you can use when you have acute pain or as a prophylactic treatment. We used to have something called the True Tier in the US. They just recalled the product, but it was another way to stimulate nerves. In this case, we stimulated the ethmoidal nerves and we caused tearing. Some of my patients loved it, some absolutely hated it. But what I found out is if you shove something up the nose, you increase tear volume, and in our population, reduce pain. But they weren't connected to each other because you can have a nerve status that is not connected to what you see on the ocular surface. I used to use it in patients who loved it, who had moderate pain and low tear production. It was recalled, but now there's a new product that's a nasal spray that's being evaluated that is thought to work with some of the same mechanisms. Another thing is that the light sensitivity really bothers patients. And I love thinking about adjuvants like tints that block out the wavelengths of light that patients are most sensitive to. The other thing that pain specialists love to do, they love to block nerves. They can block sensory nerves and autonomic nerves. This is one of my patients who developed persistent pain after retinal detachment surgery, and he wanted his eye out. Instead, we decided to inject the nerves around his eye with a combination of bupivacaine and methylprednisolone. And this is an example of how we inject. He was pain and photophobia free for 7 months. He just got his second set of injections, and he feels like he has his life back. I have found that this is most helpful in patients with peripheral nerve injury or pain that starts after eye surgery. We've also looked at botulinum toxin because it's used in migraine pain, and we have found that migraine pain, light sensitivity, and sensations of dryness all go together. In people who do not have migraine, we use a modified protocol, and we give 35 units spread over 7 sites. I don't know if I'm getting rid of wrinkles or if I'm doing something, but my patients really love this treatment. The other thing that we as ophthalmologists don't love to think about is that eye pain has an emotional component. People with eye pain are very anxious, and we think it has to do with the wiring of pain that goes to the frontal cortex and the amygdala, and this has to be addressed. We don't have to do it alone. A multimodal approach that helps acceptance-based therapies, medication to treat anxiety, anything else that works is really important. But the idea is get help, don't go at it alone. So the important things are that nerve abnormalities need to be considered in dry eye, and that the minute you hear pain, you have to think about nerve activation, put on your detective hat, and figure out why nerves are being activated. So that's neuropathic pain. But what about the other spectrum? Neurotrophic keratitis. A patient comes in, they say, my eyes feel great, and yet they look terrible. That's where I go for my trifecta of a bandage contact lens, amniotic membrane, and serum tears. And when that fails, I do have a new product that was just FDA approved in the US, and that's Oxervate. The treatment is 6 drops a day for 8 weeks. And in the clinical trial, it was better than vehicle in closing epithelial defects. I was happy with the trial because the recurrence rate was low, but unhappy because it is so expensive for my patients. This is one of my cases, a man who presented with zoster ophthalmicus. He completed his valacyclovir dose and came in for a routine exam, and this is what we saw. And this I need you to think about, because when you see something like this and you're thinking it's not so bad, no, you should panic, because in zoster, this gets bad quickly. 2 weeks later, things are not looking well. We're putting on our first amniotic membrane, but the defect is getting deeper, and a second amniotic membrane, and now we have a deeper and larger defect. At this point, we also saw some inflammation and started prednisolone, but ultimately we started Oxervate and thankfully turned around pretty quickly. And this is how we ended up. So in my hands, I don't go to Oxervate as a first-line therapy, but it has certainly been very useful in patients who are not responding to other things. And your goal here is to minimize scarring and avoid perforation, because surgical management in these patients never ends up well. Maybe not never. We have a few talks that they will end up well, but it's something that we should try to avoid at all costs. So thank you so much for including me and letting me share my thoughts about nerve status and dry eye. I appreciate it.
All right, thank you, Dr. Gloria. That was a wonderful talk. Next up on the schedule is Dr. Sandeep Mitra, who is head of department at Al Zahra Hospital in Sharjah. He's worked widely throughout the Middle East, and he's had subspecialty training in Australia and the US, with a primary area of expertise of being keratorefractive and cataract surgery. He's going to be talking to us about diagnostic tools for dry eye disease. Dr. Sandeep.
Hi, everyone. Good evening. I hope you can hear me now. So my talk today is on diagnostic tools for dry eye disease. I will restrict myself to the common investigations here. I have no financial interest. The main objective of this talk is to give an overview of various diagnostic tools available with us for diagnosis and management of dry eyes. Now, in clinical practical sequence of dry eye diagnostic tests, the most important thing is a proper medical and ocular history, the importance of all medication the patient is taking, as Dr. Garrett said, symptoms, questionnaire, the blink rate of the patient, and the first and foremost is the non-invasive tear breakup time, tear stability, memomeography, osmolarity. Then comes the invasive tear breakup time, fluorescein stain and Leishman green stain, and of course rose Bengal stain. Then comes the corneal and conjunctival staining with fluorescein and Leishman green. Of course, the Schirmer's 1 and 2, and the Sjogren's testing. The lid evaluation on slit lamp and memomeography is also very important. This is a traditional test questionnaire which you can ask for the patient. There are many of them. I'm not going to go into details of them, but there are short questions of 4 to very large questionnaire like 57 questions, and they're available in various formats in online, in iPhone app, which you can use for various purposes, not only to diagnose dry eye, but also for research purposes. Now, coming to the commonest one, which we do is the Schirmer's test, which actually tests the aqueous layer of the tear film. They're divided into 2 types, the Schirmer's type 1, which is without anesthetic, and it tests both the basic as well as the reflex tear production, and the Schirmer test 2, which is with anesthetic, and thereby we knock out the reflex part of the tear film and just measure the basic tear film. Now, it's just like a blotting paper, which is marked from 0.5 onwards. Anything which is less than 5 is considered as tear deficiency, and anything more than 10 is considered to be normal. The most important in this case is anything more than 10, the patient should not undergo any form of tear plugging, tear duct plugging. The downside of this test is we don't know whether the patient should keep the eyes open or closed during the test. There's no consciousness about it. The test must be done after stain test because the paper might disturb the surface, and avoid quantum plugs if the test shows the result that the recording is more than 10 millimeters. The other variant of the same test is called the Phenol red test. The importance of this is it is very fast to do. It takes only 15 seconds. It is also less irritating than Schirmer's paper. The thread with phenol red is placed in the infotemporal quadrant, and due to the alkaline pH of the tear film, it causes the dye to turn from yellow to red, and the length of the thread is measured. 10 millimeter or greater, again, in this case, is considered to be as normal. Tear breakup time, this is done, it's very common, easy and cheap. Fluorescein strip is wet with saline and placed in the inferior fornix. The test should be done before the lid manipulation and any use of eye drops. The patient is asked to blink freely for a few times, and then the fluorescein dye is used and observed under cobalt blue light for diffuse illumination. The time in seconds between the blink and the appearance of dark spots are counted. The test is repeated for 3 times, and average time is taken. 10 seconds or more is considered to be normal. The important point here is higher volume of fluorescein results in falsely high result. Dark spot in the same location due to any defect on the cornea or a basement membrane dystrophy is not considered to be significant. And ocular protection index, the ratio between the tear breakup time over the blink interval less than 1 is considered to be abnormal. Now, this is a test which is called the Osmolarity, which we do nowadays with tear lab. It measures the concentration of solute in the tear film. The higher the osmolarity indicates reduced aqueous and more evaporation. We collect 15 nanoliters of tear, and normal is considered to be 308 milliosmoles per liter or less. Excellent for dry eyes and poor for mild diseases. The importance is no drops should be used prior to the test, so it is just collecting the tear from the tear film and ask the patient to look upwards. Test both eyes, and the difference between the eyes are very important. So if you have a difference of 8 milliosmoles between the eyes, that gets very significant. Ocular surface dye staining, this is the classical teaching we used to get with rose Bengal stain. Of course, the problem with rose Bengal is it causes a lot of irritation to the eye. So the other dye which is very close to rose Bengal is the Leishman green. The fluorescein stain the tear film and fills any disruption in the intercellular junctions, and seen by cobalt blue light filter on cornea and conjunctiva is best seen with a yellow filter, which is the blue free. The Leishman green also stains the lid abnormalities, and if you want to use rose Bengal, you have to use anesthesia. And this is how it is graded as mild, moderate, and severe, and you see the numbers there. So depending upon the intensity of the staining and covering from the nasal to the temporal quadrant and the amount of stain, you can get it as 1, 2, and 3, and the scores are added, and then you have the Oxford grading, which tells you how severe the dry eye is. The problem is here, the fluorescein stain is carried immediately after the tear breakup time because the dye absorbs in the tissue and can make the staining blur out. This is a common test, which is the corneal sensitivity test. It actually gives an idea whether the corneal nerves are there or not, especially after patient had any refractive procedures. Decrease in corneal sensitivity in dry eye patient may be due to the damage to superficial nerves. It can be done through touching the outer aspect of the cornea with a cotton wisp, or you can have a aesthesiometer or an air jet aesthesiometer, which is a non-invasive technique. All the tests are done prior to any anesthetic drop. Even the fluorescein stain is done after corneal sensitivity. So it's important before you start using any drops to the eye, just measure the corneal sensitivity. Consider test when the signs and symptoms do not correlate. It's very important that patients with dry eyes should be examined for lid abnormalities, the anatomy, the positioning of the lid, this is entropion, ectropion, lag of thalamus, the amount of blink, the proper closure of the eyes, the tear duct positioning, and patency of the tear ducts. And the most important, of course, is the meibomian gland secretion. So you can have a clear meibomian gland secretion and graded as 0, to cloudy meibomian glands, that is 1. The 2 is granular and turbid meibomian secretions, and 3 is almost blocked, which is like a toothpaste secretion, like a thread. That is the worst form of the meibomian gland secretion. The other thing which you can look for is the meibomian gland expression. If you just press the lid over the globe, if there is all the glands are nicely expressible, it's called 0. If it is more than 3 to 4, it says 1. If it is 1 to 2, it's 2. And if no gland is expressible, that's 3. And it's also important in this case that this is one of the guidelines you can use for treatment like intense pulse light treatment, IPL, or LEP flow treatment. The other important thing is Sjogren syndrome. Now, in this case, there is patients with dry eye, dry mouth, and here you can do the serology test, which is the Sjogren's antibody test, the salivary gland biopsy. The downside is that you can have a patient with dry eyes without these markers being positive, or you can have these markers positive without dry eye, like for example with lupus. The tear clearance test is also very important. You can just use a drop of fluorescein in the lower fornix and then measure the time taken for the tear to clear up from the fornix. The normal FCT is considered to be 20 minutes. That should be, the tear should be cleared within that period of time. There is also fluorometry, is a gold standard for estimating the tear turnover and volume. Then comes the tear film stability and composition. It's very important also to know whether the inflammatory markers are present. And one of them is the inflammatory dry eye test, which is the amount of MMP9 in the tear film. There are also common xeroscope or tear film stability test, or if you don't have it, just a placido disc image from the cornea gives a very important clue towards the diagnosis of dry eye ocular surface disease. I just mentioned to you that MMP9 or matrix metalloproteinase is done for the inflammatory dry eyes, and it takes about 10 minutes. It's almost looking like a negative test means there is only a test line, which is a blue line. If there is no blue line, that is invalid test, and you need to repeat that. A positive test is a blue line, which is the control, and then is a red line, which tells you that it's positive. You can have a very faint to a very dark line, so you need to wait 10 minutes to say the test is negative. Then comes the meibomiography, which is important. Here you see a red tree image, which shows the drop of meibomian glands, or you can have meibomian glands which are choked with secretions and the known drainage of meibomian glands. The other thing is the tear volume measurement. What you can do is you can just take a slit and ask the patient to look up and measure the tear volume and the meniscus. And anything which is more than 0.3 millimeters is considered to be a normal tear meniscus. Thank you very much. And this is just our beautiful Dubai with desert and some beautiful beaches we have, which is just a contrast between the dry and the wet surface. Thank you.
Thanks, Sandeep. Thanks for the great lecture. As we said earlier, we will defer the questions to the end. If you have a question, please submit to the Q&A section, and we'll collect the questions and have a discussion at the end. I would like to introduce our next speaker, Dr. Mark Milner. He is a board-certified ophthalmologist, internationally recognized for his expertise in corneal surgery and dry eye management. Dr. Milner is the cornea director at Goldman Eye and associate clinical professor at Yale University Medical School. He will share his expertise for chronic eye disease management. Dr. Milner, the podium is yours.
Thanks, Dr. Muran. Appreciate it. Well, thank you all for having me. It really is an honor to be speaking to all of you. I really wish I was there in person. I was there about a year and a half ago. This is the picture of the Burj Khalifa that I took. And unfortunately, COVID had other plans, but I look forward to coming back soon. What I'd like to do is talk to you about the, not just the pathophysiology, but the diagnostic approach. How to, some new algorithms on how to take care of dry disease. So first, let's start with why should we be treating dry disease? Well, in the US, it's one of the most common things we see. A 2005 Gallup poll estimated that about 92.5 million Americans suffer from dry. And I know that in the Middle East, it's just as bad. Out of primary or secondary reasons to see an eye care professional, 40% of ophthalmology visits are dry related and 45% of optometric visits. And these patients are frustrated. 2009 Gallup poll showed that 81% of patients said that they were really frustrated with their disease, and 80% wish they had something more to treat dry. And then lastly, it's a hot topic, especially in the US, right? There's more diagnostic tests, as Dr. Sandeep showed. There's new treatment algorithms. But I think one of the reasons you're hearing more and more dry lectures is because we're doing more premium IOLs, more LASIK. And we recognize now more than ever how critical the tear film is to vision. When the light hits the eye, the first thing it hits is not the cornea, but the tear film. So when patients who've had, let's say, a multifocal lens come to a cornea specialist like me and say, I know I'm 20/25, but I'm not happy, it's because the tear film was not adequately treated. So how do we think about dry disease today differently than we thought about it 20 years ago? Well, first and foremost, we know it's an inflammatory process, right? There used to be this misconception that Sjogren's patients were inflammatory, non-Sjogren's were not. We now know that that's not true. Even if it's not clinically apparent, Stern showed quite nicely that there are T cells in the conjunctiva and lacrimal glands of dogs with dry eye and in humans when stained for CD3, we know that dry eye, even the white eyes, have T cells and cytokines on the surface. So we know that this is an inflammatory process. Second is that we now have treatments that go to the heart of the problem to reduce the inflammation, right? When I trained many, many years ago, we had things that just palliated. So we'd have to compound cyclosporin so that we could treat the underlying inflammation. Third is that, and this is the paradigm shift, and this is something that really is important. We now understand that dry disease may be chronic and progressive, that if left untreated, these patients may actually get worse. And then lastly, we want you to think of this as dysfunctional tear syndrome. It's a much better term because it doesn't just talk about quality of the tears, quantity of tears, but quality, meaning you may be making tears, but your tears may be unhealthy. So let's go through the pathophysiology. When we have some stress to the surface, such as a desiccating stress like wind or pollution or smoke, that upregulates our ICANS, it activates our T cells, and those T cells actually produce cytokines such as interleukin-6, tumor necrosis factor alpha, IL-1, MMP9, etc. Those cytokines propagate an inflammatory response. They do damage to the surface, but they also there's activation of the antigen-presenting cells, and those APCs travel through the lymphatics to the lymph nodes where they recruit T helper cells, such as TH or T helper cell 17. That migrates to the surface and then they get activated and it propagates this inflammatory response. So we know that dry eye is a very T cell mediated and cytokine mediated response. But what makes dry eye so complex is that there are so many different triggers and risk factors. For example, aging. We know in menopause, androgens decrease. Androgens are critical to tear production. Allergy response, a lot of different environmental stresses. Lack of sleep, computer terminals, we're blinking less when we're on our iPhones and our iPads. We know surgery such as LASIK and corneal transplants, and obviously medications, both systemic and topical. Things like antihypertensives, hydrochlorothiazide is classic as a diuretic to dehydrate us. Antidepressants and antihistamines we know for a fact cause dryness. But topically, preservatives can irritate the eye, and we know topically antihistamines can dry the eye as well. But systemic triggers such as autoimmune diseases like rheumatoid arthritis or lupus, Sjogren's, graft versus host, these can all result in immune-mediated inflammation that can therefore secrete inflammatory mediators into the tears and promote inflammation on the surface. So I gave a lecture once and someone said to me, what really is the trigger? Is this all immune? Is it all hormonal? It doesn't matter. This slide goes in every one of my dry lectures because it's a beautiful slide to show the cycle of inflammation, this carousel of inflammation that ultimately leads to signs and symptoms of ocular surface disease. And what this shows is you can have any trigger that jumps onto the carousel. So for example, irritation of the eye, no matter what the cause is, leads to inflammation. You get upregulation of your T cells and your cytokines. That inflammation leads to a shutdown of your lacrimal gland, a decrease in goblet cells and mucin, and a decrease of meibum secretion, and that leads to a tear deficiency and instability. That then leads to more irritation, which leads to more inflammation, and the cycle continues. But what's fascinating about this is you can jump onto this carousel from any point. So what kind of things jump onto the carousel from irritation? That's contacts, pollution, smoking, topical glaucoma drops, surgery, etc. That leads to inflammation, which leads to tear instability, and the cycle continues. What kind of things jump into the inflammatory circle? Rheumatoid arthritis, lupus, Sjogren's, graft versus host. That leads to inflammation, which leads to tear instability, that leads to irritation. And the things that cause tear instability that jump onto the carousel are menopause or rosacea, meibomian gland disease. But at the end of the day, it all leads to inflammation, and it all leads to signs and symptoms of ocular surface disease. So what's the bottom line? If you said, Mark, let's go to the end of the talk and give me the bottom line, bare bones basics on how to treat dry eye disease. And I know this is an oversimplification, but the first thing we have to do is treat the trigger if we can. So if you know the trigger is smoking, have them stop smoking. If it's contact lens wear, decrease the contact lens wear. If it's lupus, send them to the rheumatologist. But if you can treat the trigger, treat it. Secondly, regardless of the trigger, if you're treating it or if you don't know it, you have to break that cycle so you work the cycle of inflammation in the opposite direction. And then lastly, you have to treat it chronically. We said this is a chronic progressive disease. So the mistake that doctors make is they say, okay, we're going to treat you till you feel better and then we're going to stop it. But this disease almost always comes back. And you tell a patient they have glaucoma, they expect to be on drops forever. If you tell them they have high blood pressure, they expect to be on meds forever. But if you tell them they have dry eye, they think they're going to be off the meds in a month or two. And we need to teach them that this is a chronic process. So if we can treat the inflammation, we can work that cycle in the opposite direction. We can normalize the tear film, stimulate the epithelial healing, and we can work that neuronal feedback loop in the opposite direction. So what do we have to treat inflammation? Well, we have steroids, which are not a great long-term solution. We have cyclosporin A. In the US, we have lifitegrast that will be in the UAE soon. And then, and by the way, lifitegrast is also a T-cell immunomodulator. And then we have omega-3 fatty acids. So how does cyclosporin work? Right now, that's the commercially available drug that you have. It's an immunomodulating agent. It is a T-cell suppressor. And so what it does is it basically goes into the T-cell and prevents the T-cell from flipping the switch on, but it may not necessarily flip the switch off. So that's why it may take a few weeks to work. It does inhibit the proliferation of T cells, the activation of T cells, and the production of cytokines. So if we go to our inflammatory pathway again, we know that as those T cells come around and they come to the surface, the way cyclosporin works is it forms a complex with cyclophilin that inhibits the calcineurin phosphatase pathway, and it inhibits the activation of the T cells. And by doing that, decreases the cytokine production. Lifitegrast works on the surface. It also prevents the T cells from activating, but it works on the surface, not in the cell, so they work differently. When Kunit looked at Sjogren's versus non-Sjogren's patients, he found a statistically significant decrease in T cells after treating them with cyclosporin 0.05% for 6 months. And that was for both Sjogren's and non-Sjogren's patients. So in the US, the pivotal trials for Restasis, which is cyclosporin 0.05%, showed 4 major things. They looked at tear production for vehicle versus Restasis after 6 months, and they found all those patients that increased their Schirmer scores by more than 10 were 15% for Restasis and 5% for the vehicle. That's a 200% increase, and that is statistically significant. You might look and say, that's it, only 15% increased by more than 10 millimeters. 10 millimeters is a very robust endpoint and very difficult to achieve. And when Allergan went back to look at less than 5 millimeters increase, 5 to 10 millimeters increase, and over 10, all of them were statistically better than the vehicle. They also found a statistically significant decrease in corneal staining. So what they said was at 4 and 6 months, the patients on Restasis had much less staining or much more improvement in corneal staining than the vehicle, and that was statistically improved. But this may be the most important slide. They looked at a small subset of patients, and they said at baseline and after 6 months of Restasis versus vehicle, they looked at goblet cell density based on biopsy, and they found the 191% increase in goblet cell density for the Restasis patients compared to only a 13% increase for the vehicle. And this has been repeated by several people. I was part of a dry symposium about 10 or 12 years ago in New York with a bunch of dry specialists where Doyle Stilting and John Whitpen stood up and said, this may be the most important slide you can show in any dry eye talk, because, and I agree with them, according to them, this is the only slide that shows pathologic evidence that if you treat the inflammation with cyclosporin, you will improve the anatomy and potentially the physiology. And then the last thing it showed was a reliance on artificial tears. Obviously, the patients who were using Restasis needed to supplement with tears much less than the patients who were using the vehicle, and that makes sense. So Sanjay Rao did a study where he did the Restasis versus Endura, and what he did was he did 3 key things. One is he reproduced the pivotal studies. Anytime you can reproduce a study, you validate it. 2 is instead of going out to 6 months, he went out to 2 years. And third, maybe most importantly, it was the first study to show that if left untreated, these patients may progress in their disease. So he had 74 patients enrolled in the first year. And then what he did in the second year is he took, out of the 28 patients on Restasis, he took 20 of them and continued them on Restasis, and then took 8 of the, and switched 8 of them to Endura. And then for the 22 that were on Endura, he took 20 of them and switched them to Restasis, and actually kept 2 of them on Endura. So he did a mini crossover. And what he found was at a year, just like in the pivotal studies, there was a statistically significant improvement in Schirmer scores compared to the vehicle, 25% increase for Restasis compared to a 1% loss for the vehicle. What I felt was important about this data before we had the 2-year data was it didn't level off. I used to tell patients, well, maybe at 6 months you get the full effect on cyclosporin. But based on this, because it's not leveling off, I used to say maybe at 2 years it keeps going up. And sure enough, when he came out with his 2-year data, it was still increasing. And guess what? It's still not leveling off. So now I tell patients that at 2 years, you may still be improving on cyclosporin. When he flipped those Endura patients to Restasis, they actually, their Schirmer scores went up at the same rate as the patients who were already on Restasis. So when he looked at corneal staining, again, the same thing, a statistically significant decrease in corneal staining. And again, if you notice, this is not leveling off. These patients continue to improve even after a year. He did look at goblet cell density, he found the same thing, but he also looked at tear breakup time. And again, a statistically significant increase in tear breakup time that continues to improve on Restasis. But maybe the most important thing that Sanjay Rao showed was, he said, let's take all the patients on Restasis, let's take all the patients on Endura, and what percentage of them will progress, meaning what percentage of them have gotten worse in their level of disease. And he found that only 6% of the Restasis patients progressed, compared to 32 or almost a third of the vehicle. That means that 94% of the Restasis patients stayed the same or got better. Now, if I told all of you, you have a 94% chance of halting the progression of your dry disease if you use cyclosporin, all of you would sign on today. But wouldn't it be nice to know what percentage actually got better? Well, Sanjay didn't put it in his paper, but I saw him in a meeting and I said, Sanjay, out of those 94% of patients that actually stayed the same or got better, what percentage improved? And he said about 3 out of every 4 patients actually got better. And that's why that goblet cell density slide is so important, because it improves the anatomy and potentially the physiology. This patients may actually improve. If you look at safety, I always say the toughest patient to treat is that doctor who says, you're not giving me cyclosporin. There's never been any detectable blood levels in any study. And so you'd have to use this drug twice a day for about 2,000 years to get any detectable blood level. There's no toxicity associated. There was no ocular infections, no changes in hematology, renal or hepatic function, and no changes in intraocular pressure, visual acuity, or any biomicroscopic examination. So let's talk about the success. And I'll tell you our success in the US with using cyclosporin. I believe that some of the quote unquote failures are false failures. So I've done an unofficial survey. Granted, this is not official, and this has been over 15 years of me lecturing across the US and Canada. And I've asked more than 4,000 ophthalmologists and optometrists how much success they get with cyclosporin. And when you ask them if they get less than 25%, 25 to 50%, 50 to 75, or over 75, almost nobody is under 25%. About 1 out of 10 doctors say they get 25 to 50% success. A bulk of the doctors, maybe 60%, are getting 50 to 75% success. And then there's about a quarter of the doctors that say they get over 75% success with Restasis. Well, I asked the same question to a group of dry eye specialists that were going out to lecture in the US, and a majority of them were over 75% success. So I always say that I get 80 to 85% success. So why am I getting the 80 to 85%? And a bulk of the doctors who are quote unquote not specialists getting about 50 to 75? Well, I think it's how we define success. And the discrepancies are due to the fact that there are these false failures, right? It's not just how the patient feels. And so if a patient walks in and says, I still feel uncomfortable, yet their corneal staining is better, their rose-bangle staining is better, their tear breakup time is better, or they're needing tears less, that is another sign of success. You want to keep them on the cyclosporin. I think another big reason is the glaucoma analogy, right? One of the biggest mistakes doctors make is they don't think about dry the same way they think about glaucoma. We know that glaucoma, if a patient comes in with a pressure of 27, and you put them on a glaucoma drop and it drops to 22, and they need to be at 17, you know that you're going to add a second drop. Well, dry eye, none of these drugs are a panacea. So if a patient comes in and they're 25% better, you need to add to that. And so some patients need cyclosporin and plugs and doxycycline and maybe lifitegrast. We often use cyclosporin and lifitegrast together in the US. So no one drug is a magic bullet. And I think a 25% success on cyclosporin, where a patient says, I'm feeling 25% better, that's a success, and I would not consider that a failure. But I also think there's also the definition of failure as far as the definition of real tears and some of the other things about time to improvement, burning, et cetera. So if we look at real tears, you know, Allergan comes in and says, Restasis is a drug that allows you to improve your own real tears. And although that's true, it's not a secretagogue. So many patients will walk in and say, I feel better, yet my Schirmers are not better. Or I'm not making more tears. And that's because a success is also if you're making more healthy tears, meaning the tear volume may not go up, but they have less T cells and cytokines. So the quality of their tear is better. Also, time to improvement, right? The half-life of the T cell is 70 to 90 days. So I can't tell you how many times a patient will walk in and they'll say, oh, the cyclosporin didn't work. Well, how long were you on it? A week. Remember, some patients may get better at a week or two, but it may take 4 to 6 weeks. And as I showed you in the READY study, patients even at 2 years are still improving. They did a real-world survey looking at over 9,000 patients after the Restasis was approved, and they asked them when did they notice an improvement, and at 1 week, 31% said they noticed an improvement. At 1 to 3 weeks, 71%, and at 3 to 5 weeks, 87%. And so that speaks toward that 80 to 85% success we're talking about, but it also shows that if you ask a patient at 1 week if they're feeling better and they say no, that's not a failure. They will most likely still get better. The burning. I think if you deal with the burning, it's only 15 to 20% that get burning, but this is one of the main things to help the discrepancy. So I think burning does not mean it's hurting the eye. If you refrigerate it, you'll have 75% of those solved. And you can use an artificial tear 10 minutes before or 10 minutes after, just avoid the oil emulsions. And obviously a steroid 10 minutes before or 10 minutes after. We did a retrospective chart review looking at Restasis failures from other doctors, and we found that burning was 60% of the cause. And when we reinitiated Restasis on second trial, we got 80% success on those failures. And most of the thing that we did different is that we just told them that it may burn. And just educating them, yes, we put some of them on plugs, some of them we use steroids, but at the end of the day, if you educate them, you'll get success. As far as use with plugs, we know it works with plugs, and we know it's not a big gun therapy. It's one of the safest things, so you can use it even in early disease. So now that you know something about treatment and you know something about pathophysiology, how can we put this into practice? There are 3 main guidelines or algorithms used. I came up with the CEDARS algorithm because I wanted a very easy approach, and I think that this is a very practical approach that you can use in your practice to help with this really complex disease. Some of these algorithms are severity-based approach, so we know that mild to moderate, moderate to severe, severe and extremely severe. This is the Behrens in Cornea 2006. So this was the ITF guidelines, that international task force of specialists that convened at Wilmer to come up with an algorithm. And their treatment algorithm was based on severity. It didn't matter whether you had aqueous deficiency or evaporative. They were treating mild differently than they treated severe. And cyclosporin fell on level 2, 3, and 4, but plugs were in level 3. And the thinking was, if you plug patients before you've reduced the inflammation, you may actually raise the level of that inflammatory tear film, and you may actually make them worse. So the TFOS, or DUCE-2, came out with a really comprehensive update in July of 2017. And I always say, if you want to know about dry eye, make a pot of coffee, hunker down in your house. This is 400 pages of probably the most comprehensive reading on dry eye disease. And it really does cover everything. It gives you a roadmap or an algorithm on how to go to whether it's aqueous deficiency or evaporative. We know that most of these patients are mixed. And at each point, you can read a different paper or a different section on how to approach that. And then at the end of the day, they give you questions and they help you determine whether it's evaporative or aqueous deficient. But in the end, the goal is to restore the homeostasis. This is an organizational tool, and they even admit it's not a direct algorithm, and that it really does separate into aqueous deficiency and evaporative or mixed, but it's still based on severity. So I felt like that never made sense to me. I felt like we should be putting these patients into a diagnostic approach. So yes, you can separate into aqueous deficiency and evaporative, and Michael Lemp came up with a great way to have different diagnoses, but I felt like it had to be easier. So we got a panel together at our CEDARS Society, and we basically came up with an approach of a diagnostic-based approach that separated patients into 4 big categories. One is aqueous deficiency. So these are people who do have a quantitative problem. 2 is evaporative, based on goblet cell or mucin deficiency. It's a small category, but it can't be forgotten. because we think of evaporative as being just blepharitis or meibomian gland disease. But we know that there are patients who have cicatricial conjunctivitis, like Stevens-Johnson or toxic epidermal necrolysis or pemphigoid, that lose goblet cells and they lose mucin, so their tears evaporate quickly. And even patients on glaucoma medications can lose goblet cells, and they may be very evaporative, and they may not have blepharitis. Blepharitis from meibomian gland dysfunction is the third category, and the reason I separate it into its own category is because you can have blepharitis and have an inflamed tear film and not be evaporative. Then the last is exposure. As Anat said, patients who can't close their eye often get a type of evaporative dry eye, and if you don't forget to look for the lag ophthalmos or the partial blink, like you see in Parkinson's, you'll miss this. Now, Anat also talked about the co-conspirators, and this is the fifth category, those diseases that either masquerade as dry eye or contribute to it, meaning the patient sitting in your chair and says, no matter what I do, you're not getting me better, I just don't feel better. Start thinking about those diseases that sound like dry eye, but are not, like SLK, medicamentosa, Tygason's, mucus fishing syndrome, contact lens related toxicity, chemical toxicity like hairspray, allergic or atopic because one, the symptoms sound alike, but also they're on antihistamines, as Anat showed you, conjunctivitis and floppy lid. But if you can separate these patients into four categories: aqueous deficiency, evaporative based on goblet cell or mucin deficiency, blepharitis, both evaporative and non-evaporative, and exposure, understanding that these are not mutually exclusive and they often overlap, well, then you can separate these patients and come up with a much more directed or pointed treatment. So doing things like Schirmer's and looking at the tear lake. And I know Sandeep covered some of this stuff, looking at rose bangle, that classic wing-shaped pattern that you see with keratitis sicca, you make the diagnosis of tear deficiency. If you do a tear breakup time, you have conjunctival scarring and you assume they have goblet cell deficiency, especially if they don't have blepharitis. That's the goblet cell and mucin deficiency. Anterior, posterior blepharitis or lid erythema debris blepharitis. And then looking at their lid function, you can get exposure. Once you do that, now you can have a directed treatment with all those things that will be directed toward that category. And some of these are esoteric, some things that you may not think about. So we know that for tear deficiency, tears, plugs, supplements, etc. Cyclosporin and lifitegrast we know work. Autologous serum is a great option. We also can use secretagogues, not approved in the US, but in Japan they have diclofosol. And then I like to use a lot of compounded medicines like medroxyprogesterone or DHEA, which is a topical androgen, or a 50-50 testosterone progesterone mix. I think that works great as anti-inflammation, and topically it works excellent for the tear deficient patients. There's lac research, moist chamber goggles, we know omega-3 fish oils. One of my favorite treatments is albumin. If you can't get autologous serum, topical albumin is a great treatment. It has a mucoadhesive effect. There's also dapsone or tacrolimus, which helps to suppress inflammation. TrueTear, as not mentioned, nasal stimulation, which is not available anymore, scleral lenses, and then surgery. For the goblet cell deficiency, we know cyclosporin actually can increase goblet cell density. I'm a big proponent of using vitamin A ointment. We know vitamin A replenishes goblet cells. There's an overseas, over-the-counter Vitapos that you can get on Amazon that works great to use at bedtime, and then there's moist chamber goggles and scleral lenses. For blepharitis, we know cyclosporin, Restasis works great. Eric Donefeld and Hank Perry did a great study looking that Restasis works as well for blepharitis as it does for aqueous deficiency. Topical azithromycin, I love compounding metronidazole ointment. It works like Metrogen on the face. Oral doxycycline, for people who can't tolerate oral doxycycline, I like using doxy drops compounded or clindamycin. And then there's things like pulse light therapy and LipiFlow. And then for exposure, I usually refer that to my plastic specialist. So in the end, we start with cyclosporin or Restasis because it treats the first three categories, and it's the commercially available drug that I can use to reduce the inflammation. But if somebody comes in 4 to 6 weeks on cyclosporin, and I ask myself, are they 100% better? If they say yes, stay on the Restasis, I'll see you back 6 to 12 months. No, then we initiate a second treatment based on their categories. So if they're 50% better and their Schirmers are still low, now I'm going to plug them. If they're 50% better and they still have significant blepharitis, I'm going to add azisite or topical metronidazole. If they're 50% better and still evaporative, I'll add vitamin A ointment. Then I keep them on 2 treatments, see them back 4 to 6 weeks later, and then I initiate a 3rd treatment if they're not 100%. In the end of the day, where severity comes into my algorithm is, if they come in with graft versus host in their first visit and they have marked keratitis and Schirmer's is 0, they may get restasis, plugs, steroids, antibiotics, all in the first treatment. So thank you. I hope that was a simple approach for you. Again, I wish I was there with you. When I come back, I would love to go to my other passion, which was Dubai Creek, and play golf. It's a beautiful course. You have a beautiful city there. And I really appreciate you inviting me to talk today. Thank you so much.
Thank you for that really comprehensive talk about dry eye disease, Mark. That was great. Once again, I'll just repeat that we'll be keeping questions until the very end of the session. So if you have any queries, just type them into the Q&A box. So next up is Dr. Saj Ahmed, who's a corneal and external eye disease consultant at Moorfields Eye Hospital, City Road. And he's an honorary senior clinical lecturer at the Institute of Ophthalmology, he's a clinical professor at UCL London. His area of expertise is corneal and ocular surface stem cell biology using both adult and pluripotent stem cells. And that's what he'll be talking to us about today, the management of limbal stem cell deficiency. Thank you, Saj.
Thank you very much, Hamad and Murad, for asking me to speak. So I'll give you a quick run through limbal stem cell deficiency. The limbus is very important for 2 main functions as far as the ocular surface goes. The first is for epithelial renewal because it contains the stem cells for the corneal epithelium. And the second thing is it acts as a physical barrier between the conjunctiva and the cornea. So it separates the vascular conjunctival stroma and the hazy-looking conjunctival epithelium from the normal clear corneal epithelium. And in limbal stem cell deficiency, both those functions of the limbus cease to occur. So you get failure of epithelial renewal and you get chronic epithelial defects, as you can see here in the photograph, and you get conjunctivalization of the corneal surface. And the resulting symptoms are not only loss of vision, but these diseases are very painful, similar to the neuropathic pain that we described earlier, where the nerve endings are generating pain locally, but then becomes much more of a chronic problem. Now, limbal stem cell deficiency is a clinical phenotype. It isn't the cause of the what you're seeing. There are many, many causes of this, and they occur because the limbal stem cells are either lost, such as in chemical burns, or they're not working very well, such as in aniridia-related keratopathy. And the easiest way to think of it is to break it down into 2 major categories: primary or hereditary causes, which primarily are aniridia, where you have a PAX6 mutation, or ectodermal dysplasia patients, where you have a P63 mutation. And these diseases, by nature, tend to occur bilaterally. The larger group of patients are actually the ones that have secondary or acquired causes, and these can be either bilateral or unilateral. And the easiest way to think of it is in the 4 eyes. So you have injuries such as chemical or thermal burns, inflammation, so this is patients with mucous membrane pemphigoid, Stevens-Johnson syndrome, GVHD, chronic atopic disease. You have patients who have iatrogenic limbal stem cell deficiency from when we give mitomycin C for topical neoplasia, for example, or where we remove large portions of the limbus, again in oncology. And there are a small group of patients where you never find a cause, and the likelihood is that they probably have some sort of genetic origin. The clinical features of the disease are very important because they guide what you're able to do for the patient for rehabilitating their surface and their vision. You want to know whether or not the disease is partial or complete, whether it affects the whole limbus or whether it's just 1 or 2 quadrants. Whether it's unilateral or bilateral, because that will enable you to determine whether or not you can use one eye as a source of the stem cells, or whether or not you require a cadaveric source or a non-ocular source, such as oral mucosa. It's not always progressive. So you will have some patients that have 360-degree conjunctivalization, but they will have a spared central cornea. And for those patients, they may never progress. So you don't really have to do anything. The main features when you clinically examine the patient are the loss of the palisade. So if you have a look at this photograph here, you can see these ridges, and they're very common in the superior and inferior limbus in particular. And these are actually the undulations of the basement membrane at the limbus that increases the surface area that the stem cells have exposed to the vascular contents underneath. And these disappear. And in aniridics, this is very common. So in the first and second decades of life, you look at your aniridic patients and you look at their ocular surface, the palisades disappear, and it's a very flat looking appearance. The next thing that you look for is delayed fluorescein staining. So this is where you put full strength fluorescein on the surface of the eye, and you leave it there for 5 minutes until you can use that time to speak to the patient or to do a Schirmer's test without anesthetic. And what you'll see is this sort of demarcation where you get this mottled epithelial surface, mottled staining. It's very it's much coarser than punctate stain, and you can see this clear segregation between normal corneal epithelium at the top and conjunctival epithelium at the bottom. And then you have the classic features of limbal stem cell deficiency, which we're all used to seeing: the corneal vascularization and the persistent and repeated epithelial defects. You often, you can get conjunctivalization without vascularization, which is why it's important to do the fluorescein staining in particular. When you aim to treat these patients, your primary aim is actually not to rehabilitate vision. That comes as a secondary parameter. For the patient, obviously, that's the most important, but your primary aim is to stabilize the ocular surface and normalize the corneal phenotype. And once you've done that, you've prepared the eye for secondary procedures such as a corneal transplant. So your primary aim in this is really to rehabilitate the ocular surface, and then your secondary aim is to improve vision. This is the complex flowchart for limbal stem cell deficiency, and I won't go into great detail, but some of these treatments are historical. There's obviously the Cincinnati protocol is in here, where you've got the large allograft procedures. The ones that I'm going to concentrate on are what we consider really the gold standard, and I'll show you the trials that highlight the outcomes from those. So those are the cultured therapies, where you can expand out the stem cells using laboratory methods. So I'll highlight it by going through the first patient I ever treated about 15 years ago now in the autologous group. So this is a patient who had one eye burnt and the other eye was healthy. So you take a small biopsy of about 1 to 2 millimeters in diameter. This heals very quickly in their healthy eye. So the results show that there's very few risks, if any, to these eyes. You then take it to the lab, and there's a technique. The technique that I'll show you in a moment is one where we grow it on amniotic membrane, and we take that explant, put it on the amniotic membrane, and submerge everything in the patient in a growth medium that's composed of the patient's own serum. We require lots of regulation around this with good manufacturing practice procedures and European Medicines Agency approval as well. So it is a lengthy process to go through, but once done, everything's set up. So what happens in those 2 weeks? And I'll go back to this slide. You can see in the picture of a culture at the top, in the photograph, you can see a small explant, and around the explant there's a circle of tissue, and these are the epithelial cells growing out from it, and that will cover the whole of that amniotic membrane, a period which takes about 2 weeks. And then once you've got your cells grown, you go to the eye that's had the injury, and you do a 360-degree peritomy, and you remove that conjunctival pannus. I have a video here, but due to time constraints, I won't show it. If needed, I'm happy to show it later. You then do a sandwich technique. So you have your amniotic membrane with the stem cells grown on top, and you put this on the deconjunctivalized corneal surface. And then on top of that, you put another amniotic membrane that goes from conjunctiva to conjunctiva. And that's known as the sandwich method because the stem cells are protected by the two amniotic membranes. And what you notice over a few weeks is that the overlying amniotic membrane disappears and its vessels grow onto it. But because it melts, those vessels, that sort of amniotic membrane that overlies it, protect the cells that are growing underneath. And it disappears. By about 6 to 8 weeks, the amniotic membrane overlying has gone. And the outcome that you get is, this is again the first patient who I've just shown you there. He had an injury about 13 years prior to seeing us. And this is his eye beforehand, and he sees hand movements. You do your stem cell procedure to normalize the corneal epithelium, and you can see after the procedure, the eye's very white. So it's amazing actually how significant a surgery you do. It's quite a destructive process doing a 360-degree peritomy and essentially doing removing a significant portion of tissue from the front of the eye, but these eyes are very quiet afterwards. So this patient had it done, had 660 vision afterwards, but was pain-free, no recurrent epithelial defects. And then a year later, we offered him a corneal transplant, which was, these are often penetrating because of the nature of the chemical burn, as was the case here. The endothelial cells are also compromised as the anterior chamber is affected. So you do a penetrating graft and they get very good vision. So he's got 6/9 vision at the end of this process. And he's now, as I say, 15 years on, still very good vision and has two healthy eyes. So we then went on to do the clinical trial, and this was 10 patients, and in all of them, you can see that there's a significant improvement in vision and pain. And this then resulted in the process going to European trials, which I'll go into in a moment. We then went on to do look at allogeneic procedures for patients that had bilateral injuries. And we went on to do a randomized control trial, which is actually the first one in our field. And we had a treatment arm, which was to culture the cells of amniotic membrane, just as I've shown you before in the autologous one. And we immune suppressed the patients with mycophenolate. We then had a control arm where the patients got a transplant of just amniotic membrane and immune suppression, just as in the treatment arm, but no cells that were growing on top. And this trial included all patients with disease in both eyes. And we had various centers in the UK. Over a 4-year period, we recruited 18 patients. Recruitment was quite slow because patients didn't want to have the control arm, the control treatment. And interestingly, in the treatment arm, 4 out of 5 patients had aniridia-related keratopathy, and in the control arm, 4 out of 5 had chemical burns, where we already had the data. And if you look at the graph here, in blue you have the treatment arm, and in red you have the control arm. You see at 6 months after surgery, because of the lower score that you have for limbal stem cell deficiency, the composite ocular surface score, you see they still have very comparable improvements in the two groups. But as you go to 12 months and 18 months in particular, you have a significant regression in the patients with the control arm. So this highlights that your cells that you're transplanting have the main effect in these patients. And this is the first patient I did on this trial. So this is a patient who had a contact lens associated injury, thiomersal injury from the 80s in both eyes. So she had fluctuating vision, but essentially had 660 in both eyes, chronic photophobic eyes and pain. And I did the surgery, and 12 months after the graft, you can start to see her previous transplant that she had done many years ago. And you then go on a year afterwards and do a corneal transplant. She gets very good vision. So this lady's, again, you've rehabilitated the eye as a 2-step procedure, and you have to do that. We then took part in the Holocaust study, which was the European study, involved originally 12 centers, but eventually 16 centers within Europe. This was a slightly different autologous treatment where the amniotic membrane was replaced with a fibrin carrier. And this was to look at, again, burns. Patients had to have burns for 24 months prior to having this treatment so that the eyes were calm before your surgery. And all the biopsies were sent to Italy prior to COVID for this process, and it's only just opened up again for further procedures. This is now a licensed treatment, so in the UK we were able to do this on the National Health Service for any patient coming through. If you can't do those processes where you culture, there are other techniques. So there's the simple limbal epithelial transplantation technique, which Virendra Sengwan from India originally developed. And this is where, rather than taking the biopsy from the healthy eye and sending it off to a lab for culture, you actually directly chop up the biopsy into small pieces and then grow it on the amniotic membrane on the eye that has the disease anyway. So after you've done a superficial keratectomy, and the large autologous and allogeneic studies show this to be almost as effective as the cultured therapies. If you don't have access for some reason to immune suppression, or don't want to do immune suppression, the patient doesn't want it, then you have the option of using oral mucosa and growing that up on amniotic membrane. And this was these are the studies that Shigeru Kinoshita from Kyoto developed, and there are reasonable long-term studies. I think the data is still not as good as the limbal pieces, but if you've not got the ability to immune suppress a patient for some reason, then this is a suitable alternative which gives a patient back some visual, gives them some visual improvement. So just my final slide, this is just to show the algorithm that I currently use for managing patients with limbal stem cell deficiency. And if you have no visual axis involvement, you don't have to do anything. If there's less than a third of the limbus affected, so it's partial limbal stem cell deficiency, you do a partial epitheliectomy and put an overlay amniotic membrane on top. But if you've got disease that's more than a third of the limbus, and you've only got one eye affected, you'd go on to do the autologous treatment, so the auto-slet, and then if that fails, then the cultured therapies, which are much more expensive. If they have disease in both eyes and you can immune suppress them, then you'd go down the allo-slet or the allo-cultured therapy route. And if you couldn't immune suppress them, you go and do COMET. And I think that's my last slide, but that's essentially, 20 years since we originally developed cultured therapies. This is where we're at, and for patients that previously had no treatment available, we're able to rehabilitate the eye quite successfully now with a success rate of about 76%. Thank you very much.
Thanks, Saj, for the excellent presentation. I'll pass for Dr. Asim Ali, who are our next speaker. Dr. Asim Ali is an ophthalmologist in chief at Hospital of Sick Children in Toronto and the chief of pediatric services in the Department of Ophthalmology at the University of Toronto. Dr. Ali is one of the world leaders and expert in corneal neurotization, and we are lucky to have him today to share his experience. Awesome. The podium is yours.
Thank you, Murad, and thank you for the invitation to speak. I'll be speaking today about neurotrophic keratopathy and corneal neurotization. My financial disclosures are not applicable to this talk. The fundamental problem with corneal anesthesia is twofold. It combines a lack of injury awareness that leads to late presentation, as well as poor healing. And some of the previous speakers have talked about this. This poor healing of the epithelium can lead to infections and stromal lysis and perforation in its final stages. The nerves provide support to the ocular surface, and there are factors that affect epithelial migration and growth, such as nerve growth factor IGF-1 and substance P. The other thing to remember is that sensory innervation also reduces secretions from your lacrimal glands, your goblet cells, and from your meibomian glands, so compounding the issue with the poor quality of your tear film. There are multiple causes of corneal anesthesia and neurotrophic keratopathy, and some of these were alluded to, the most common being herpes simplex or zoster keratitis and diabetes, and other forms of ocular surgery, including penetrating keratoplasty, endolaser during retinal surgery, and includes transscleral laser for glaucoma. Less common causes, which can actually be a bit more severe in terms of complete anesthesia of the surface, include severe head trauma, posterior fossa, mass lesions or hemorrhages, and globally leprosy. And in my practice, I see a lot of congenital causes, and the most common of that is actually an isolated corneal or trigeminal anesthesia. The treatment considerations in neurotrophic keratopathy can include the classification or stage of the disease. So the Mackey classification is most commonly used, ranging from punctate keratopathy or punctate keratitis to a stromal melt. And what you'll see is that most patients actually cycle between stages depending on their disease. And it's very common for acute exacerbations and remissions of this disease. So most patients will have either 1, 2, or 3. And really the question is, at the time of a given stage, what therapy are you going to use? If you're considering surgical intervention, you really also need to consider what's the visual potential of the eye, and also how long has the corneal anesthesia been there, especially for some causes that are potentially reversible, such as with posterior fossa tumors. Medical treatments are very important, and again, some of these have already been discussed, but you can use preservative-free lubrication and autologous serum tears, and now nerve growth factor is available in some parts of the world, and it can be very helpful. Punctal plugs, bandage contact lenses are very helpful, and I have used PROSE lenses, which are a type of scleral lens, very successfully in these patients, and they can improve vision due to the irregularity in the ocular surface and in the cornea itself. Nerve growth factor is now available in the US, and the most recent pivotal trial used this 6 times a day for 8 weeks. These patients had ulceration of their surface, so they had Mackey stage 2 or 3, so either just epithelial ulceration or stromal involvement. And most patients had herpes zoster or simplex or were post-surgical. And these were all adult patients. The primary outcome of this study was epithelial healing. And that's important for what I was going to discuss later with neurotization. Dr. Galore mentioned that there is an approximately 70% healing rate after 8 weeks of treatment with the Syndrom versus vehicle, which was about 30%. The secondary outcome from the study was an improvement in sensation as measured with Cauchy-Bonnet esthesiometry. And this was seen in both groups, but was not statistically significant. And of note, Syndrom improved sensation from about 9 millimeters to 29 millimeters. So the patients had some residual sensation to start with and did have an improvement. Focusing on surgical therapy, the goals are threefold. The first one is to try to treat or prevent breakdown of the ocular surface and to halt melting. A tarsorrhaphy is actually very, very helpful in these patients, and a short course of this can sometimes reverse breakdown very, very quickly. Amniotic membrane can be used as an overlay, and you can consider a Gunderson flap as well. Tectonic support can be from an inlay of amniotic membrane, either using glue or keratoplasty, although these don't tend to be very successful in this group in terms of preventing scarring. And finally, the new paradigm is to try to reinnervate the cornea, which is the idea behind corneal neurotization. So just as a general overview, amniotic membrane can be used in a number of different ways. You can be sutured in, you can use it with a ring, which includes the Procare device. You can use it with tissue glue as well. A multi-layer technique can be used, although this has not been so successful in my hands. And I've seen a number of these fall apart or destabilize. Tectonic procedures with cyanoacrylate glue is very helpful with desmetaseals and small perforations. And we use a small plastic disc to sort of smoothen the surface of the glue and allow the eye to heal underneath. Keratoplasty is not ideal in these inflamed eyes, and I've seen a number of these have persistent epithelial defects after and is usually a last stage emergency technique. Gunderson flaps are helpful, but it makes any subsequent procedure for visual rehabilitation difficult. And I would not consider this in an eye that has good visual potential or where the duration of corneal anesthesia has been shorter and there's been not a chance given for spontaneous improvement. So corneal neurotization is a technique to reinnervate the cornea and addresses the underlying disease process. And it's something that you should consider if you have an eye with good visual potential. The eye's ocular surface should be stable, and it really is not a procedure that you would use for an active ulceration because of the time it takes to bring back sensation and improvement of the ocular surface. So what is neurotization? It's not a term that's familiar to most ophthalmologists. It's a regeneration of a nerve after it's been divided. And any nerve that's been transected will attempt to regenerate and grow into denervated tissue. And when you either redirect a nerve or use a nerve graft, you can bring back innervation to injured areas, both for sensory purposes and also for motor. And it's commonly used in peripheral nerve surgeries, for peripheral nerve injuries, and for brachial plexus injuries, and for reanimating muscles elsewhere in the body. So the principles are used that you can use either a nerve graft or nerve transfer. This has been used in the past using a direct technique, so a nerve transfer technique. Was reported by Terzis, who is a plastic surgeon, and the original technique that was described here was reflecting and dissecting out the supraorbital and supratrochlear nerves on the healthy side, bringing them over to the affected side and towards the limbal area of the anesthetic cornea. And this technique used a bicoronal flap, which is across the top of the head, a very large forehead flap, which had significant morbidity and took a lot of surgical time. There was a very slow, inconsistent return of sensation, and this was not a technique that was widely adopted or indeed well known in the ophthalmic community. We proposed a minimally invasive technique using a sural nerve graft. The sural nerve graft is harvested from the back of the leg. And in this schema, you can see it's attached to the contralateral supratrochlear nerve and then tunneled into the cornea, the anesthetic side. And what happens then is the axons grow along the graft and then into the cornea. I think we have enough time. I can quickly show this video. And this shows a child who has a right congenital corneal anesthesia. And the two sides are marked. The left side is normal. The right side is insensate. And these are the two incisions that are made on the face. On the leg, the nerve is then harvested from the back. This is using a nerve stripper, which is a little bit like a fascia lata or Crawford fascia lata stripper. And you can remove a significant segment of the sural nerve without a significant donor deficit. I get often asked this question. You end up with a 2 to 3 centimeter in diameter defect on the side of the heel. So it doesn't have any impact on ambulation, and that improves with time. The nerve graft is passed underneath the skin. And now I'm working on the right eye, which is insensate, using a right needle, which is used for ptosis surgery. This is going to bring the graft, the nerve graft, into the superior fornix. And in no time should the nerve graft be exposed either at the skin level or when it's underneath the conjunctiva. So it'll be remain buried throughout. The nerve itself, the actual donor nerve that you can see here, is actually composed of a number of smaller fascicles. So this is like taking a wire and stripping off the coatings. And the number of nerve fascicles is variable. We've seen as few as 2 and as high as 11, and has something to do with the size of the individual. The actual number of fascicles doesn't appear to impact the degree of sensory recovery, however. Then you then pass the fascicles underneath the conjunctiva and tenons around the limbus, and hold it and handle it only by the ends if possible, and then remove any devitalized or crushed tissue. And here what we're doing is just securing the fascicles at the limbus with 10-0 nylon And we now actually just bury the nerves in the little scleral pockets. And I don't really have time to show more of the technique modifications we've used. So after this, we would do a tersorrhaphy and a coaptation of the nerve. We published last year outcomes from our first 15 patients, which were largely children, but they included 2 adults. So the oldest was 34. These are mostly congenital, but there were acquired causes, which included 1 case of herpes simplex keratitis. The nerve grafts were placed in a variety of different ways. We were able to treat both bilateral and unilateral disease, as you can see here, and we had 1 patient who was treated with an infraorbital nerve graft. Our primary outcome was corneal sensation as measured with Cochet-Bonnet esthesiometry, both centrally and in 4 quadrants. The longer the filament that is produced, the more sensitive the eye. And so you can get up to 60 millimeters with this technique. Our outcomes with central corneal sensation were pre-op. As you can see, most patients had very little sensation at all, close to 0 measurable with this technique. And at final follow-up, we had normal sensation, at least maximum sensation measurable in the majority of patients. And we had 1 patient fall below a threshold of 20 millimeters at final follow-up and would be considered a failure. And this is out of 15 patients. Post-op appearance 6 months after surgery, it shows the nerve grafts sort of regressing and translucent in appearance, and they do tend to shrink with time, but the amount of sensation that you see, it doesn't decrease at all. We reported on our confocal microscopy results, and with normal contralateral normal eye, which you can see here on the left. The left eye was insensate for congenital reasons, and there were no detectable nerves. Those are vessels and scar tissue. And at 6 months, we start to see some new nerves sprouting in the subbasilar area and anterior stromal area. This allowed us to perform corneal transplants, and this is a DALC procedure 2 years after the transplant, which is nice and clear. We were able to do 3 transplants in this cohort. 1 of the patients actually had a triple procedure done, and all of the grafts had epithelialized and with improvements in vision in this group. Looking at the buttons that were removed, 1 patient had had 2 previous perforations, then 2 previous transplants, and we were able to look at this tissue and look for nerves. So in this 1 particular patient, the second graft shows extensive scarring and vascularization, and we used a neurofilament stain which showed no nerve growth in these 2 prior buttons. The third graft, however, was performed after neurotization and showed these linear figures that you can see here that are positive for neurofilament in both the patient and in controls. It showed evidence of nerve regeneration. In terms of any future directions, the technique of direct neurotization has been improved by a number of coworkers. And this is through a small lid crease incision and dissection of the supraorbital and triple-trochlear nerves. And they've had good results reported with this technique. The infraorbital nerve has also been approached, and different donor nerves have also been used, including the greater auricular nerve. Allografts are of interest as well, and we've been currently developing animal models, including a rat model and now a mouse model of neurotization to look at the effects and the mechanism of this therapy. So neurotization can improve both corneal sensation and ocular surface health and treats both congenital and acquired causes. There are now multiple techniques and modifications, and it's really going to be interesting to see which one is better. The role of nerve growth factor and the place in therapy versus this therapy is unclear. And certainly the 2 overlap in terms of their indications. And this is, neurotization is obviously a much more invasive technique. And the last thing is to identify the timing and place in surgery of therapy for neurotrophic keratopathy. And these are my 2 co-developers of this technique, Ron Zucker and Greg Borchell, and our first patient. And I'd like to thank our trainees and my other colleagues who supported me in this work. Thank you very much.
Thank you, Asim. That was a great presentation. So we've come to an end of the actual planned sequence of talks today, and I'll be opening the floor to some questions. There are some questions which have already been submitted. First of all, for Mark Milner, there's a bit of interest regarding the sort of auxiliary treatments that you use, such as autologous serum, albumin, topical dapsone. Could you tell us a little bit about your preferred concentration for autologous serum and how you go about preparing dapsone?
Sure. So as far as autologous serum goes, I used to make it in my practice. It's really not that hard to do. You can use a centrifuge, you draw the blood. But, as far as the US goes, the FDA is coming down on practices doing it themselves unless they have a hood. So now there are eye banks in the US that are doing it. And I start with 20%. That's my go-to. 20% serum. We usually put it in a type of artificial tear. I often use Refresh, to be honest with you. But I've gone as high as 50%. Now, they talk about using 80%. I have never gone to 80%. 50 is the highest I've gone. But I've had great success with 20%. As far as some of the other immunosuppressive agents, dapsone's been used. I don't have a lot of experience with dapsone. I actually have more experience with using tacrolimus. And I use that more for atopics than for dry, although it will work for dry as well. A lot of these compounded medications like albumin or topical hormones, I get from our compounding pharmacies. I use VLS in Brooklyn, New York, and they'll ship it right to the patient. And honestly, it's very well tolerated. It's not that expensive. In the US, it costs about $80 to $100 per bottle. And I've gotten great success. And what I really want to stress is, I always start with the commercially available drugs like cyclosporin. But when they need more, like we said, multi-treatment, I will go to they're great adjuncts to using with cyclosporin to help these patients that need more than just Restasis and lifitegrast in the US.
Okay. Got a question for Dr. Asim. What's your feedback regarding calcical eye drops?
We don't have those available in Canada. I don't know if they're available in the US. So I don't really have any experience with that.
I think it's available in the UK. So Saj, any experience with calcicol? I know I've used it when I was in the UK, but let's hear your experience.
Yeah. I think we tend to use it for patients when we're really, really struggling. So, for patients that you're then thinking of maybe putting on a nerve growth factor, or you've probably gone beyond serum and amniotic membrane. And I have to say, I've had a handful of patients on it because I'm not sure it works very well. But N equals 5 isn't enough to say it's not any good. But I think it's not available anymore, or it's being withdrawn or something. So by Taya.
Okay. There is a question here from Momin Arifi asking about do you think surface epithelial ablations, PRK, and other LASIK procedure might play a role in causing anesthetic corneal disorder? If so, does small procedure would be the right alternative? Anat, can you share your experience on that?
Sure. I think that any surgery that disrupts corneal nerves can change function. If you measure corneal sensation right after PRK or LASIK, it's going to be reduced. And generally, sensation recovers, but not to baseline levels in all patients. And some people have no consequence from this. They don't have pain and they don't have tear abnormalities, but some do. And you can have pain by itself, tear abnormalities by itself, or both. The SMILE is newer. There are data that suggest that biomechanically and from a nerve damage perspective, SMILE is better tolerated. But I think that being that it's a newer procedure, we still don't know how it's going to compare long-term. From an anecdotal experience, I haven't seen ocular pain post-SMILE as frequently as I have post-LASIK, and PRK is not as common as well. So most of my ocular pain patients who have had refractive surgery have had LASIK, but I also have pain patients that have had other surgeries like cataract surgery, cross-linking, scleral buckle. So I think it doesn't happen often, but you can develop ocular pain after any surgery.
Muran, can I add to that? I think one of the things that we have to stress is when we're doing these refractive procedures, we're very strict in our practice at examining them for dry eye and ocular surface disease, because there's no question that if you take these patients into a refractive surgery and you have not addressed their dry eye, their ocular surface problems, their we check sensation on all of our patients, then you're just heading for trouble. So I guess preemptively is even maybe as important as post-operatively as well.
I have a question for Anat. How do you choose which conjunctival chalasis patients to actually treat in clinic? I mean, I see tons of them.
Right.
Never really sure exactly who to actually, do something invasive to, or for that matter. So how do you go about choosing which patients to treat?
Right. So in my hands, I'm looking for people who I think the conjunctival chalasis is contributing to the problem. And most of my patients with chalasis, they'll complain of some sort of pain, dryness, aching, burning, but they also complain of tearing because we think that the anatomy has changed and the tears don't always have a place to go. And I want to see significant chalasis. My approach to chalasis, there are many different ways to approach it, but I use a cautery technique, which is an in-office technique. I numb it up, I pinch, and then I cauterize over it. They look terrible at a week, and when you cauterize conjunctiva, it becomes red and irritated, but at a month, they look perfect. So I stopped seeing them after a week. And at a month, everyone's happy. So because I don't have to take them to the operating room and I can do it in the clinic, it's generally very well tolerated. If they fail traditional metrics and I think chalasis is a problem, I generally address it because it's so easy to do.
Okay, thank you.
I might add to Anat, I do exactly the same thing. I also look if the conjunctival is more toward the nasal part, which most likely interfere with the tear flow and cause a lot of tearing. Those are the candidate for me to do a procedure for. I do it a little bit different. I inject glue subconjunctivally and then I resect the excessive conjunctiva. It works the same. It heals nicer as well, and you don't need to suture or do anything aside from that. I would like to ask Saj about the experience. I know that cyclosporin 0.05% is not available in UK. We use Curvis, which is 1 milligram per ml. So what's your experience with it in terms of the dry eye disease? Do you use it much for?
So it's Curvis is cyclosporin 0.1%.
Mm-hmm.
And as you know, we have the 2% veterinary ointment as well. So we use both. And if patients, the studies, there are two studies that Santen produced. One was the Sansica and one was the Sicanova studies. And they actually correlate well with the Restasis studies that Mark just highlighted earlier. And, the longer you use it, the more improvement you seem to get in the symptoms. But there are patients that don't respond, and there are cyclosporin non-responders. And then you're stuck with what can you offer them? We don't have lifitegrast here in the UK. We don't have dequathizole here in the UK or Europe either. So we're then, hunting around for serum drops and other modalities. We actually we've just completed a trial where we've used finger prick autologous blood. So if patients don't get access to serum because they're relatively expensive and they're a bit difficult to get sorted, then we give patients diabetic lancers, and they can use they finger prick their blood just as diabetics do, lower the lid, and then they can just put their own blood in, and that trials for once, twice a day. And some patients respond really well, especially the neuropathic. For Anat, the neuropathic patients seem to respond the best. And as you know, some of them have had their neuropathic pain for years and are at the end of their tether. They can't function, they can't work, and some have psychiatric problems. I've had had patients that have been suicidal, and you know, sometimes fingertip autologous blood works. There's more to blood than just serum.
Really interesting.
Saj is absolutely right. There are patients who don't necessarily respond to cyclosporin, but what I've found anecdotally is, and off-label in the US, is you can bump up Restasis to 4 times a day, and you might get some success on that higher dosing as well. So that's another trick to basically bump it up to, and it's done safely, and we've had really no adverse events by bumping it up. It is off-label.
I just want to stress on a point that, Mark, you mentioned in your presentation about the side effect or the concentration of 0.05% was not detected in blood. And this is always reassuring for the patient whenever you tell them that you will be starting them on cyclosporin. So this is a very reassuring point. I mention it to my patient when I start consulting them about starting them on cyclosporin. Any questions, Hamad, you want to ask? Or
it's been...
I'm looking through the questions.
Some really good questions for do these Q&A comments show up for everybody, or is it just for us? Because there are a couple of really good questions for Saj.
I'm
not really sure. So
they're for us.
Okay.
Right.
Well, it's a really good point about how do you choose between doing a CLAU versus an autoslet?
So CLAU is the original technique, so developed in 1989 originally. So it's an older technique, but has good results. You need more tissue. So I always go for the autoslet first anyway. And then if that doesn't work, then I go on to the cultured therapies if there's failure. So I have probably only in my career, 20 years, done 2 CLAUs, but you know, my predecessors have done many and they work just as well. You just need more tissue. So, and it's best to do surgery with less tissue if you can.
And any reasons why you chose mycophenolate or CellCept in your study? Any particular reason?
So because it was a trial, we had to choose one immune suppressive drug for everyone. So there wasn't any variation. We chose mycophenolate because most of the sites were experienced in using it. It's a safe drug to use. But it's, you know, now that the trial is completed, there's no reason why you couldn't have cyclosporin or oral cyclosporin or azathioprine as well, as long as there's immune suppression. You use it for about a year.
Yeah. Okay, thanks. Thank you.
Just a quick question about Sandeep. We mentioned earlier about the serum drops. I use 20% here in Abu Dhabi. I think, Hamad, you do the same as well. I'm not sure if Sandeep, about your experience in Dubai, do you use it? Is it easily available for patients if you needed to put them on serum drops?
Yeah, actually what we do is we have the pathologist who help us to prepare these serum drops. The problem is we don't have a very sterile way to prepare it in our outpatient. So we actually help, we get the help through the pathologist. But there is a company which is now helping us to prepare the platelet-rich plasma, which is called the PRP. And it's a very sterile technique wherein the orthopedic surgeons, they use it for various knee related issues. So we are using their machine to get PRP-rich plasma, platelet-rich plasma for dry eye patients.
You know, what's coming down the pike too is we talked about amniotic membrane, and specifically the cryopreserved really preserves those fetal complexes that help with healing. Companies like BioTissue and other biologics are coming out with amniotic drops and or things like umbilical cord drops that will help in patients who can't get autologous serum. And that is coming down within the next couple of years. And so that will really change people's ocular surface as well, because those studies not just show improvement in things like dry eye, but they also especially the cryopreserved, has shown nerve regeneration as well. So that's another option.
I have a question for Prof. Miller. At what age do you recommend restasis drop for children? Do you have any age recommendation for them?
Yeah, so I have no problem. It's not approved for children, but I have no problem using it. There was a question, actually, I saw, what other diseases can use cyclosporin? And actually, to that point, one of my favorite diseases is Tygasons. We know that cyclosporin works great for Tygasons. I'd rather use cyclosporin on a child with Tygasons than use steroids, because the side effects are so, it's such a safe drug. The one caveat to that is, for Tygasons, I will use it 4 times a day until it's improved, and then I'll maintain them on once or twice a day. But the lesions, we don't know what the cause is. We think it's viral, but we see those Tygason lesions basically melt away with cyclosporin. So I have no problem using it in kids. The second one that kids get is meibomian gland disease. You know, blepharitis is so common, but children get more neovascularization, more scarring, and so I have no problem using metronidazole as well as restasis in kids who have terrible blepharitis and meibomian gland disease. And I've used it for years. And then the third one is atopic or vernal. We know that atopic and vernal are both an IgE-mediated response, which means a histamine response, as well as a type 4 or T cell response. So for those patients, I love using with vernal and atopics. I'll use restasis twice a day, and I'll use whatever your favorite mast cell stabilizing agent is, whether it's olopatadine or now Zerviate, which is topical cetirizine. I'll use that twice a day. And I've gotten great maintenance of having both antihistamine and cyclosporin for those atopics and vernals. And again, very safe in kids.
Thanks, Mark. Saj and Ahmed, can you share your experience? I prefer actually to use a stronger percent for VKC and atopics in terms of cyclosporin.
So there are studies. Vacasia was the EMA approved cyclosporin 0.1%, which was used BD or QDS for vernal patients, and that's it was a really good study actually that was, I think, published a year ago. And the evidence is that you need to use it at much higher frequency than standard dry eye preparations. In the kids, the cyclosporin ointment works very well. It's easy to administer. The most cyclosporin preparations, have a side effect of being irritable. Whereas the ointment prep doesn't do that. And the other option is obviously to use tacrolimus in kids with vernal. I was actually going to ask, can I ask a question to Mark about how do you get hold of the albumin drops?
So again, albumin is compounded. I'll get it at VLS in Brooklyn. I don't know if they can ship overseas, but I can always ask them to send you how they compose it. But it's basically the same albumin they use for a hydrodynamic study, that they inject into the blood, and they make it into an eye drop. But it's all compounded, and they'll send it right to the patient. It's great it really has a mucoadhesive effect, and I've had patients say that it's the only thing that helps with their symptoms.
Thank you. Yes.
If there is any more questions, I find that most of attendees are still with us, so please feel free to ask any questions. Awesome. Can you share your experience with the atopics and VKC kids? How do you manage them?
So we have access to Vacasia in Canada, and it's essentially the same thing as Icurvis. So they have it's a cationic emulsion of 0.1% cyclosporin, and in the trial, the results have been better with using it 4 times a day and for maintenance. So I've used that. Prior to that we used compounded cyclosporin, so either 1 or 2%, and that was generally more effective than using restasis, which is 0.05%. So I would use compounded cyclosporin or Berkasia, and tacrolimus ointment is available off-label. You can use the dermatological form here, which is protopic. And for atopic children, it can treat both the eyelids and the eyes. So we use a combination of those things and try to avoid steroids as much as possible. They're probably, that population and the blepharitis population are the most likely to abuse steroids. So I'd like to get them off of that as quickly as possible. And one other comment for the blepharitis patients, I will often use oral antibiotics, so azithromycin or doxycycline in those children, and they give you you get long-term remission if you use it for long enough.
Another great trick for terrible vernals. Vernals can get shield ulcers. So one of the things we did in our fellowship was we would double avert the lid and go super tarsal. You give a little injection of Kenalog. You can't get a lot in, it's a very tight space, but if you put like 1/10 of a cc, you don't really get the pressure spikes because it is super tarsal, but you'll see those shield ulcers melt away and you'll see the cobblestone papillae resolve. I mean, it really is like a magical treatment for terrible vernal where the other stuff doesn't work.
Yeah, I use that. A lot of those are very chronic patients. Taking drops takes a very long time.
I think you made a great point in that, especially in patients with atopic keratoconjunctivitis, it's an eyelid periocular skin issue as much as an eye issue. If you don't get the skin under control, it's very difficult to get the eyes under control. So we love tacrolimus ointment in that regard. And in my severe cases, I use oral tacrolimus when these are patients that have had disease for years and on and off steroids. And in the few patients I've had to use that, in the very severe ones, I've had great success.
I see a question about how for Dr. Milner. How long would you keep a patient on doxycycline? You are muted. Mark, we cannot hear you. You are muted.
Sorry. That happens all the time in Zoom conferences, right? I actually will use doxy a lot in my posterior blepharitis, but I've actually started using it less and less. We know that for the anti-inflammatory effects, you need less than you do for the antibiotic effects. So you can use 50 milligrams, you can use even once a day, or 40 milligrams, or even Periostat, which is 20 milligrams. So I'll usually start with 50 BID if it's really bad, and then I'll go to once a day, and I'll use it for 3 to 6 months. But I have to tell you, I've gotten, between the risks of sun exposure, especially here in Southern Florida, and yeast infections, I've actually gotten away. I do like using oral azithromycin better than doxy. I also my combination of using cyclosporin and topical metronidazole or a topical azithromycin, or now for people who can't tolerate oral doxy, again, VLS will make doxy drops twice a day. And so you can use doxy drops topically, and it really helps the posterior blepharitis. So even though I still use oral doxy, especially if they have facial involvement, I've gotten away from oral as much as I can by using some of these esoteric compounded medications. To answer your question, I'll go 6 months to a year as long as they're on a low dose or longer. But I also like them to be followed up by their internist, obviously, for the systemic side effects.
I start them on around 6 weeks and then reassess, as you say, the side effect. And if I find the patient tolerated it and they had a benefit out of it, I'll probably keep them. It depends on the severity, up to a year or so on. Any other questions, Hamad? We are almost reaching our end, actually, but there is a last question from Osama to Saj, I believe. Is Saj with us still?
Yeah.
Can you read it over there?
Let me have a look. I don't think I can see all the questions.
It says, in a previous study at East Grinstead, They didn't find donor DNA after 1 year of cultured stem cell graft. So maybe there's no need to use systemic immune suppression after 1 year.
Yeah, that's correct. So that's why I said earlier, when you use the mycophenolate, you can stop it after a year. The reason we don't always is because if we're going to do a corneal graft, then your graft is a high-risk graft. So you might want to continue it for a year after that for the purposes of the corneal transplant.
All right. I think we reach our time end. I would like to thank all the speakers and the attendees who stayed with us until this late time in UAE. Thanks everyone, and I wish you a great evening.
Thank you. Thanks for having us.
Thank you.
Be safe, everybody.
Bye-bye.
Thank you. Bye-bye.
Thanks everyone.